This is Charles Clinton, and it's a Sunday, so I don't have my scrubs on or anything like that. Just casual here, ready to take the dogs out for a walk. It is April 4th, 2025. I'm starting to study for the ABIM board exam, so this is going to be mainly internal medicine question bank, and I'm going to just try to answer 14 questions the quickest I can. So I will just walk you through whatever I am doing. I'm ramping up, once again, the efficiency on how to take these tests and all that, but let's see it. So as you can see, this is going to be unused questions, all the subjects, all the systems, and we're not going to do it time, we're going to do it tutor. I'm just going to be the quickest possible. Let's do 14 and generate the test. Okay. So the idea is just to answer this the quickest possible. Let's get this out of the way. Navigator, what's this? No, I don't want this. Just so you can see me. I don't want to see the labs. Where can I? Resources. I think it's here. Oh man. Let's get the labs out of the way because it's not that. Resources. Let's make this big. Let's eliminate hide answer. Because I had this here so I could see this. Notebook. No. So yeah, it's important to know how we're using these things. No, here. Get out of the way. Okay, now we're gonna do this again. Here we are, okay. So, the quickest we can. Which of the following is the most appropriate pharmacotherapy? So immediately go to the question. Don't start underline nothing, just read the question. And these are the options. Bupropion, nortriptyline, paroxetine, quetiapine, venlafaxine. So we're seeing atypical antidepressants. We are seeing TCA. We're seeing SSRI. We're seeing atypical antipsychotic and SNRI. So, how can we decide this? Well, patient is not hypertensive, so we still have all in the picture, and we have to see, okay, let's skim through it. 32 years. I'm just going to tell you what words will be like triggers for us to choose one answer or the other. So yeah, he seems depressed, sleeps all day. Is sleeping 12 hours a day, has suicidal ideation, no delusions. The patient has history of depression in his 20s, now he's 32. He responded poorly to fluoxetine, and the patient is now sort of trying to hurt himself. Probably I would take an SSRI maybe out of the picture. Maybe we can try it again. Let's see. Hospitalized 2 years ago after being arrested for aggressive behavior when police attempted to restrain him as he entered government building without authorization. Patient wanted to explain his strategy of world peace at the United Nations. So this patient not only has depression, this patient has bipolar disorder. So giving him SSRI is not the answer. And if you have bipolar disorder, what can you give? It's not going to be paroxetine. Okay, let's continue. So yeah, strategy, or maybe bipolar, maybe schizophrenia, right? Following discharge, he did not follow up with treatment, takes no medication, had asthma, drinks beer on weekends, no other drugs, has depression, and his family, maternal grandfather treated with nortriptyline. Okay, that's interesting. Why nortriptyline? Okay, blood pressure is normal, physical exam unremarkable, most appropriate pharmacotherapy. So I don't want to give this patient an SSRI with the possibility of these things going on, right? Obviously, severely depressed mood, no energy, sleep all day, miss work, can't motivate, sleeping 12 hours a day, suicidal ideation, no delusions or hallucinations. So this isn't schizophrenia, so I would say not this. I don't recall. I would look for a mood stabilizer. This seems to be like too activating. Probably don't do, no. I would go with an SNRI, because I would say SNRI over paroxetine. Although I don't recall the data on this medication, but I'm almost certain it's probably not going to be paroxetine. Atypical antipsychotic. As a mood stabilizer, I wouldn't take it out of the picture, to be honest. I would take this one out. I would take this one out. I'm leaving it between these two. If I had to choose, bipolar. Seems like bipolar. Or, yeah, I don't know why I'm still liking quetiapine. Seems like he has no. It seems like I think this one sometimes you can do for mood stabilization. But for bipolar, I always think of lamotrigine. I think about valproic acid, carbamazepine. And what's the other one? Lithium, right? But I'm guessing probably this one's now in the picture. Let's go. Yeah, that's the answer. Second generation antipsychotic quetiapine is a first-line treatment for bipolar depression. Antidepressant monotherapy should be avoided in patients with bipolar 1, type 1 disorder due to the risk of switching to mania or inducing rapid cycling. So there you have it. So now I learned this new point that I can also add quetiapine to bipolar depression treatment. Probably this medication, when I studied for step 1, it wasn't so much used. I mentioned the ones I recall, the older medications that were effective. As you can see, there is also evidence for efficacy of mood stabilizer, lithium, and lamotrigine and valproate. I mentioned all those others, but I didn't recall quetiapine. So let's add quetiapine into the mix. Now you know it, quetiapine, and that's it. Let's go on to the next question. We're taking too long. Which of the following additional measures is indicated at this time? So I don't even know what's going on, but let's see. Bed rest for 5 to 7 days is never an answer. Active mobility or quick mobility is the best. This is not going to be the answer. Unless it's a pregnant patient and she's 76. No, and probably not. Early mobilization is always a good answer. Cyphoplasty might be MRI of the spine, rigid, thoracolumbar brace. These rigid things are also becoming less and less common. So we have these 3 options. 76-year-old, severe back pain, slipped on a wet tile floor, fell against the toilet, was not able to stand, went to the hospital, has Alzheimer's and osteoporosis, lives in an assisted living facility, vitals normal, nothing quite special on the physical exam, midline tenderness in the lower thoracic spine, neurologic exam, decreased ankle reflexes bilaterally, with normal lower extremity motor strength sensation and knee reflexes. Okay, so all that is good, just the ankle ones are decreased, but they're present. The chemistry and blood count is normal, x-ray shows wedge compression fracture of T12. Because the patient continues to rate pain as 9 out of 10, despite 2 oral analgesics, she is admitted for parenteral pain control. Which of the following is indicated at this time? Okay, so is this patient at risk? Does this patient need a surgery right now? We aren't that sure yet. So this patient is saying their pain is horrible, and they are on 2 medications. So would we start mobilizing this patient immediately without figuring out what else might be going on? The answer is no. The question now is, do we have enough information to make this patient mobilized? Maybe not. So let's see. We do have an X-ray showing wedge compression fracture of T12. So it doesn't say convoluted. It doesn't sound like that bad. But let's see the clinical aspect. So yes, patient has severe pain. So now let's think about the neurologic exam. Decreased ankle reflexes bilaterally. So but strength is normal, sensation is normal, and there's not any shooting pain. It doesn't say the patient has any like bowel, like incontinence or sort of things that would be more worrisome. And oftentimes these patients, does the patient just have decreased reflexes of these two, of the ankle reflexes? That's the usual, right? That I always see that. It's always hard to get them even on normal patients. So kyphoplasty, not sure I would rule that one out. Yes, the patient has a lot of pain, but it's not so many concerning factors. So would I want an MRI or not? Just because there's reduced ankle reflexes bilaterally, that doesn't make much sense. Why aren't there other manifestations? It's too isolated. So I would probably go with early mobilization as the right answer, to be honest. And I think rigid thoracolumbar brace. The patient has so that's in the mix again. So I would prefer this one over this one. I probably still wouldn't image. And early mobilization doesn't seem like it's fixing much. Maybe here it's like we don't want to worsen that up. Wedge compression fracture of T12. Have I seen these people with the rigid thoracolumbar brace? Not that often. But I'm not an orthopedist. I'm internal medicine. They're not complaining of anything else. But maybe it would be a good idea to stabilize this, right? So it heals if you're not going to operate. So in this case, I'm going with the brace. The brace is probably the best balance I can find. How long ago was this? Early mobilization, yes, that's going to be important. But the patient continues to have that pain. So tough to go against early mobilization always. Kyphoplasty, MRI of the spine. I'd go with the brace. Although I don't see it that often, I'll go with that. It was early mobilization. You see it there. Early mobilization, 45%. Okay. Let's see why we got it wrong. Following vertebral compression fracture, patients should resume normal activity as soon as possible. It's compression fracture. Excessive bed rest should be avoided because it is associated with decreased functional capacity and additional loss of bone density. Once the pain improves, physical therapy can be initiated. Goals include core strengthening and gait training for fall prevention. Why wasn't it rigid thoracolumbar braces? They are not well studied for VCF. VCF is vertebral compression fractures. Limited evidence suggests that they are not significantly better than soft braces or no bracing. That's why I don't see anyone with these braces or very infrequently. So let's go on to the next one. Which of the following is the most likely cause of this patient's hypotension? So we see cardiogenic shock, early sepsis, hypovolemia, pericardial tamponade, and pulmonary embolism. So immediately I see a cardiac index right here of 1.5. When it's below 2.1, it's usually cardiogenic. So immediately that would make me think that it's not sepsis. Even hypovolemia shouldn't give me this, not this. Although if it's a severe pulmonary embolism, it could alter my cardiac index. This could also alter it. This could alter it, but not these two, I believe. So right atrial pressure is 10. Right ventricular pressure, 36/15. Pulmonary artery pressure seems elevated. Yeah, because it seems elevated because now the definition of pulmonary artery, pulmonary hypertension was 25 mm mercury. Now it's 20. If you're seeing this diastolic of 18, you already know that the diastolic is elevated. So you do have pulmonary hypertension. Is it because of the left side of the heart or not? We don't know. Oh yeah, here we have it. It's the left side of the heart because the wedge pressure is elevated, telling you that the left side of the heart is affected. So if it's not going to be pulmonary embolism, so it's going to be one of these two. Probably it's not this one because it's saying it's the left side of the heart. And this patient has had, here you see coronary artery disease. So the answer is going to be cardiogenic shock, and that's the answer. Patients with cardiogenic shock will have a low cardiac index, increased systemic vascular resistance, and elevated pulmonary capillary wedge pressure. So just to talk about what we saw here, cardiogenic shock, you have right atrial pressure. It's going to be elevated. Pulmonary capillary pressure, mean is 9. This was around 18, was it? 24? Yeah, mean is 9, but usually when you say this is altered, as a cardiologist, you're talking usually above 14, 15, right? Cardiac index, normal is 2.8 to 4.2, but well, below 2.1 is cardiogenic shock. SVR, vascular resistance, 1,150, and mixed venous oxygen saturation. Here you go. Okay, so that was the answer. Which was the other one I had? Pericardial tamponade. Let's see why not D. Tamponade causes increased right atrial and ventricular pressures and characteristic equalization of right atrial, right ventricular, and diastolic, and pulmonary capillary wedge pressure. So we would have had several of these pressures. Pulmonary artery, right ventricular would be equalized, and right atrium, right? So we didn't find that. Interesting. Let's go on to the next one. So which of the following is the best next step in management here? Options: bowel preparation followed by colonoscopy, contrast enhanced CT of the abdomen and pelvis, MR angiography of the abdomen with gadolinium, stool culture and Clostridium difficile PCR, and upper gastrointestinal endoscopy. So we have a whole lot of options here. We have to first think, what can we rule out? So I always go, usually I see the labs and then I go to the rest. Just a little bit of leukocytosis, anemia, leukocytosis, and normal platelets. Okay. So this patient is 72 years of age, has end-stage renal disease. Usually, end-stage renal disease, you want to avoid gadolinium. So probably let's cross this one out for now. Unless the patient is on dialysis. So pain started in the lower left abdomen at the end of dialysis and has remained steady in intensity. So I'm not crossing that out yet. The pain does not radiate and is unchanged with movement. The patient rushed to the hospital after noticing bright red blood in the bowel movement 30 minutes ago. Mild nausea, no vomiting, back pain, fever, urinary symptoms. Other problems are hypertension, diabetes, hyperlipidemia, depression, gastritis, and he developed anuric end-stage renal disease due to hypertension and diabetes and has been receiving maintenance hemodialysis for the past several years. No recent antibiotics or travel and hasn't ate anything special. Former smoker with 30-pack year history and does not use alcohol or illicit drugs. Temperature is fine. Blood pressure is normal. Pulse is normal. Abdomen shows tenderness in the left lower quadrant with decreased bowel sounds. There's no rebound, tenderness, or rigidity. Okay, this sounds like diverticulitis, right? Because it's right lower, where is it? This left lower abdominal quadrant. There's a little bit of anemia, leukocytosis. So I wouldn't do a colonoscopy because it could perforate if it's diverticulitis. CT, yeah, that would be a good one. Doesn't sound no risk factors for C. diff. It doesn't sound like this. It's gonna, and this one not necessary right now. Diverticulitis, we want to see the pouch. We want to see if it's perforated or not, but it doesn't sound like it's perforated, and we're gonna answer that, and that's the answer. You can hear the dog ready to go out to run. We're gonna go take them for their usual walk. So ischemic colitis usually presents, oh, it was ischemic colitis. Usually presents with abrupt onset of abdominal pain over the affected large bowel with subsequent hematochezia. CT scan is the preferred initial diagnostic study to rule out extensive bowel injury. Diagnosis is subsequently confirmed with colonoscopy. So I thought this might be diverticulitis. Okay, that's interesting. Why is this? Acute onset abdominal pain and hematochezia is typical for colonic ischemia, the most common form of ischemic bowel disease affecting the elderly. Okay, and it's usually due to hypovolemia or decreased effective arterial blood volume, leading to decrease in flow. Okay, all that. And a patient has several risk factors for ischemic colitis, and the abdominal CT with IV contrast is the preferred modality to rule out extensive bowel damage. And colonoscopy usually done subsequently to confirm diagnosis of ischemic colitis. Okay. Okay, so it doesn't mention anything about like diverticulitis being a possibility, but that's okay. That's okay. So let's go on to the next question. That's it for that one. Objective learning. Let's see why it wasn't C. Because most cases of colonic ischemia are non-occlusive. MR angiography. Okay, this is the vessel, right? So this isn't. This would be for something else. Maybe like mesenteric ischemia, although CT would be the one to be performed as well. Gadolinium should not be used in patients with significant renal impairment due to the risk of nephrogenic systemic fibrosis. So even if the patient is on hemodialysis, better avoid the gadolinium due to nephrogenic systemic fibrosis. Let's go on to the next question. Which of the following is the most likely diagnosis? So we have nephrolithiasis, paranephric abscess, renal cell cancer, schistosomiasis, renal tuberculosis. So how often have you seen renal tuberculosis? If it's not on the test, you've never seen it probably, almost never if you're not an infectious disease doctor. This one probably is going to be out of the picture unless they're asking us a pretty low yield thing. There are no casts, there are no crystals. Okay, schistosomiasis, there's always hematuria, so 5 to 10 is not elevated. So if they're asking me schistosomiasis, I would go with this. If they're asking me for renal cell, I would go, yeah, I would expect hematuria, and I would also expect hematuria and nephrolithiasis. It sounded like paranephric, but there's no abscess. But I would expect maybe some leukocyte esterase or white blood cell count. I'm not sure what's going on. Let's see what else is going on. The hematocrit is elevated, so elevated hematocrit seems like, why is there elevated hematocrit? We'll see. Platelets are normal, leukocyte count normal, creatinine, yes, some acute kidney injury, calcium is okay, glucose is okay. The liver function test, nothing out of the ordinary, and the UA is normal. So, okay, so when everything is bland, I would bring this one into the picture. I would take this one out, and I would think nephrolithiasis is a good option. Like everything looks normal, but the patient has horrible pain. Let's see what's going on. Patient doesn't have a fever, so that goes up against abscess. Okay, there's no hepatosplenomegaly, but there is some pain to deep palpation in the right flank. Okay, 60-year-old comes from India because of intermittent fevers and weight loss over the last 3 months. Fevers and weight loss over the last 3 months. For the past 10 days, he has also experienced a dull ache in the right side of the abdomen. And he considered himself healthy until 3 months ago. He denies mostly any symptoms, no history. So the idea, immigrants coming from somewhere or another, usually for the test, it's telling you there's something going on. I'm not seeing anything special here. Negative, negative, and none. And this dull ache and this intermittent, so paranephric abscess can be a reason. Paranephric, it's not like in the kidney, so it might be around the kidney. That might be the reason there's not much going there. But I would expect leukocytosis. There is none. Renal cell cancer can generate, okay, weight loss, fever, yeah, and that might be the reason for paraneoplastic syndrome generating the increased hemoglobin. So based on these things, that would be my answer. So that's the answer. Renal cell cancer can be asymptomatic or present with abdominal pain, mass, or hematuria. Advanced renal cell cancer can be associated with a variety of paraneoplastic syndromes, including hypercalcemia, erythrocytosis, and weight loss. So that was the answer for that one. So there you have it. Okay, why wasn't it? Yeah, we already walked through the others. So let's go to the next question. In addition to antifungal therapy, which of the following is the most effective strategy to improve this patient's outcome? So the patient is on amphotericin B, and they're asking us what else could you start this patient on? Acetazolamide, corticosteroids, immediate antiretroviral therapy, mannitol, and serial lumbar puncture. So from what comes to mind, have you ever read something on amphotericin being added to acetazolamide? Not me. So I'd say no to this, maybe to this, no to this, maybe to this, and no, not sure to this. So now let's look. Oh, opening pressure, 490 millimeter water. That's very elevated. That's like, I think that opening pressure above 25 millimeter water is 250 millimeter water is already up. It's hypertension. So endocranial or, yeah, hypertension. ICP, increased intracranial pressure. So there's increased intracranial pressure, so we want to reduce that somehow. Maybe it's this one, but depending on what this patient has. 50-year-old man brought to the ED, fever, malaise, worsening headache, last 8 days. History of advanced AIDS, non-compliant. CD4 was 29, so this patient can have anything. And has hepatitis C, febrile, disoriented. Remaining exam is remarkable. Open pressure, we already said it. Glucose is 47. Protein is elevated. Leukocytes, a little bit elevated, not so much maybe. A lot of monocytes, so that's interesting. And red blood cells 0. India Inc. shows, okay, so this is crypto. We maybe didn't have to go so high. Patient with crypto, you should do these. I would say it's that. Yeah, okay. That's the correct answer. Cryptococcal meningoencephalitis usually presents in HIV patients with headache, fever, stiff neck, and possible altered mental status with neurological deficits. Treatment involves prompt antifungal therapy in 3 phases. So there's induction, consolidation, and maintenance. Patients often require serial lumbar punctures to reduce the increased intracranial pressure frequently seen with infection. Why wasn't it also recommended therapy in HIV patients with cryptomeningoencephalitis? First, the induction, as we mentioned, amphotericin and fluticasone. That's the recommended. Consolidation is the next 8 weeks. Fluconazole, 400 to 800 milligrams daily, and maintenance is for the remaining year or the next year. Fluconazole same, but we reduce those to now 200 milligrams daily. There are some alternatives, but will the test actually ask you about the alternatives? I don't think so. At least know the main ones, the basics. Okay, amphotericin and flucytosine, first 2 weeks, then only fluconazole higher dose for 8 weeks, and then for a year, 200 milligrams fluconazole daily. Go on to the next question. Let's do 10. Only 10, and that's it. This x-ray looks horrible. There's blunting on everything. This looks like honeycombing. Of course, honeycombing isn't something you usually see on the x-ray. It's more like CT, but yeah, but it sort of looks like it, right? So, and this is horrible. Both sides. Both sides look horrible. So, let's see. Which of the following is the most appropriate next step in management? Probably, based on these options, PEEP, tidal volume, this looks like ARTS. So let's confirm it's ARTS, and if it's ARTS, we can say this one isn't the answer. Chest tube isn't the answer because it's both sides. This one probably isn't the answer. Maybe this one is the answer, but this one is probably definitely the answer. Increased PEEP. So 36-year-old woman to the ED, short of breath and cough for 4 days, has rheumatoid arthritis, interstitial lung disease, pulmonary hypertension, and patient is intubated, afebrile, hypotensive, a little bit hypotensive, not in shock, but shock index is above 1, meaning that heart rate is above systolics. So that's it. That's telling you the patient will go into shock soon if we don't do anything. Pulse ox 100% on assist control with tidal volumes 300, respiratory rate 220, FiO2 100%, and PEEP of 5. So the lowest PEEP basically 5. Examination reveals right-sided crackles and decreased breath sounds on the left. Okay, loud second heart sound. That's telling you there's a pulmonary hypertension. And what else do we have? Abdomen is soft. Hemoglobin, patient is anemic. Leukocytosis going on. A little bit of hyponatremia. Bicarbonate is normal. BUN, creatinine normal. Calcium, all that is normal. pH is 7.32. PaO2 is 86 and PaCO2 is 50. So what's the P to F ratio? It would be P to F, PaO2 of 86 over, so we would do here over 100. So it's 86. 86 over 1.0 is 86. So it's pretty low. So this patient needs proline and everything. I would say increase PEEP. No, we don't have to do this. No, that's okay. And it wasn't that. Reposition the endotracheal tube. Okay. I hadn't seen this, but here you can see it then. This endotracheal tube went to the right main stem bronchus because this is the left main stem. This is the carina. So a good positioning of the tip of the ET tube would be a couple centimeters above this, like 1.5 to 2 centimeters above the carina. So this patient is only ventilated on the right. So this patient, you would expect them to develop atelectasis and problems on the left pretty quickly. Oh, that's why they said that you couldn't hear much of breath sounds on the left, I think. Let's see it here. Decreased breath sounds on the left. So that's telling you, yes, this patient isn't being ventilated on the left. So here you have it, what we just spoke. Proper position of the ET tube can be confirmed by auscultation, observation, and insertion depth. A chest radiograph is required to confirm placement. So that's it. That was the answer. Let's do just a couple more questions. What is the best next step in management for this patient? MRI liver, percutaneous biopsy of dominant liver nodule, sorafenib therapy. Sorafenib. I had generated a mnemonic for sorafenib. I think it was for hepatitis B or hepatitis C, chronic hep B or C. I think it was chronic hep C. But let's see. Surgical resection of dominant liver nodule and ultrasound follow-up in 2 to 3 months. Okay, so let's see what's going on. Alpha fetoprotein is pretty high, so probably not going to be following this up. We have to figure out what this is. Is this cancer or not? Nodular cirrhotic liver and a 2-centimeter dominant nodule with poorly differentiated borders in the right lower lobe. So remember, cirrhosis is a high risk for hepatocellular carcinoma. So why don't you just get the biopsy? The MRI won't tell you much. This won't tell you much. Even if they have hepatitis C, you want to biopsy that. So I'll do this and go from there. And it's not that. It was MRI of the liver. Let's see why. Current guidelines suggest routine surveillance with ultrasound every 6 months in patients with chronic hep B infection and or cirrhosis. MRI of the liver has better sensitivity and specificity than CT or ultrasound in differentiated malignant nodules from the regenerative nodules associated with cirrhosis. Lesions less than 1 centimeter can be managed with ultrasound follow-up in 3 months. So why what? Let's see this algorithm. Workup of liver nodules in high-risk patients. So liver nodule on screening ultrasound. Okay, you got it. There you have it. It's less than 1 centimeter. Repeat ultrasound in 3 months. And keep on doing that. If it's more than 1 centimeter, okay, now we do a contrast-enhanced MRI or CT scan. Diagnosis confirmed. And so basically this tells you, is this HCC? If you have the right clinical picture and you have the imaging going with it, you might not need the biopsy and you just can say, okay, this is hepatocellular carcinoma or this is benign. So that's basically what it's telling you. If the diagnosis is not confirmed, then you go to biopsy versus serial imaging. So what I want to see is what imaging was done here. Oh, it wasn't ultrasound. It wasn't a CT scan. Okay, so I thought this was a CT, so I was biased, so I thought nothing else was required. So that's it. So let's go on to the next question. And the last one, oh, we're going to 9. So let's try to get to 10. Which of the following is the most likely cause of this patient's hypercalcemia? And we're going to go quick because the dogs want to go out. So 125 vitamin D is elevated. So what things elevate this? Not parathyroid adenoma. Sarcoidosis does increase vitamin D activity. Squamous cell wouldn't, that I can recall. Yes, it could be vitamin D intoxication. And thyrotoxicosis, I'm not sure it's associated with that. Intact PTH is normal. So it's a hypercalcemia that is not associated to PTH. So that's the first thing you check, PTH. It's not associated to PTH. Now we see vitamin D and PTHRP, etc. So let's see what else we have here. 51-year-old, persistent dry cough after upper respiratory infection 2 months ago. Let's see if they're taking pills over the counter. Ex-smoker. So this is saying this might be a problem, right? Blood pressure is normal. BMI is normal. Abdomen soft and non-tender. Remainder of the exam is normal. Chest X-ray reveals higher lymphadenopathy. So I'm taking out vitamin D intoxication. They're not telling us anything about over-the-counter vitamin D pills. 2 centimeter left lower lung nodule. Okay, left lower lung nodule. Which of the following is the most likely cause of this patient's hypercalcemia? So I bring back to life this one, and now we have these 2 options. They're not saying that the patient is African American. They're not giving us more information for us to suspect this is sarcoidosis, and there is just reveals higher adenopathy. So there's higher adenopathy and a 2 centimeter. Oh, okay, but it's dependent on 125. This isn't squamous cell wouldn't elevate this. It would be PTHRP. And this wouldn't be elevated. So I'm going with sarcoidosis. That's the answer. Patients with hypercalcemia and elevated 125 hydroxyvitamin D require a chest X-ray to evaluate for granulomatous diseases such as sarcoidosis and lymphoma. So that was the answer. I walked you through it, and basically these nice algorithms are to evaluate later. But what did we do? We saw PTH. PTH was normal. So high, normal, or elevated. Suppressed PTH. It wasn't suppressed, or was it suppressed? Yeah, it was 15. So it was suppressed. So PTHRP we didn't get. This was elevated 125. So here you have a lymphoma or sarcoid. Okay. Let's go on to the next question. Last question. Which of the following would most likely be present on this patient's EKG? You have these options. Abnormal Q waves in the inferior leads, electrical alternance, left ventricular hypertrophy, right bundle branch block, or short PR interval and delta wave. So let's see what's happening. 37-year-old school teacher for a preventative appointment, no symptoms, hasn't seen a doctor in many years, takes some vitamins and calcium over the counter, is quite healthy, temperature is normal, blood pressure normal, pulse normal, respiration normal, vitals normal, jugular, venous pressure normal, cardiac auscultation reveals now we find something. Wide and fixed splitting of the second heart sound. So fixed splitting of the second heart sound. Usually there's physiologic splitting is that it just splits, I think, during inspiration. Was it inspiration? But it shouldn't be fixed. So there's a 2 out. Let's see what else we have. 2 out of 6 mid-systolic ejection murmur. Best heard over the second left intercostal space. 2 out of 6. Second. Yeah, this looks like right, but this is left. Left. Second left, okay. Remainder of the physical exam are remarkable. Which of the following most likely be present on the EKG? Mid-systolic ejection murmur. Mid-systolic. Okay, and the second is the second wide and fixed splitting of this. So when you have systolic murmur here, pulmonary, oh, this is telling you basically pulmonary. If this is the pulmonary artery, it's going to be pulmonary, yeah, can you have it with pulmonary stenosis, fixed splitting? Yeah, because it would close later. If you have pulmonary stenosis, it closes later. What other sound can it be there? Systolic. That's about it, or the main thing. Electrical alternance, no, this is tamponade. Left ventricular hypertrophy, no. Yes, probably right bundle branch block because there's probably pulmonary hypertension going on. Abnormal Q waves in inferior leads now, short PR interval. This is Wolff Parkinson White, so I would go with right bundle branch block. That's the correct answer. Atrial septal, and it was an atrial septal defect. That's why that's the other one. It's called machineria. Atrial septal defect. No, that's PDA. But it's the persistent ductus arteriosus. You can see like the machine sort of murmur that is very loud and it's not necessarily clinically significant, but you listen to that and it's like. But in AST, it's not necessarily so marked. So why does this generate a fixed splitting of the second sound? Because you have a interatrial communication, so it means that there's more flow from the left atrium to the right atrium. There's increased flow there. Let's see why, and let's see the explanation. Atrial septal defect causes right-sided volume overload, which is responsible for the characteristic cardiac auscultatory findings, i.e. pulmonic flow murmur. So there was no stenosis, no necessary stenosis. Another reason for a murmur is increased flow, right? Wide and fixed splitting of S2, because if there's more flow, it will take longer for P2 to close. Remember, S2, second heart sound is A2, P2. So aorta closes right after pulmonary closes. If everything's going fine, it'll be almost at the same time. But if there's more flow going on the right, aorta closes, and it takes a couple more moments for pulmonary to close, and it's going to be fixed because the flow increase is constant on the right. So aorta closes, wait a couple moments, pulmonary closes. Fixed splitting of the second heart sound, and many of the frequent observed EKG abnormalities, like right axis deviation, right bundle branch block. And that's it. Now it's time to take the dogs out to walk, and I'm heading out. I'll see you later. Well, thanks for joining. Leave me feedback. What do you think? And comments, opinions, etc. How many right do we have? Let's see. Navigator. Oh, it doesn't say how many right. So let's see how many we've got right of these. Can we see it or no? Review, resources, navigator. So let's just see. We have to go through all of it. We have 1, or how many wrong? 1. How many wrong? How many wrong? We have only 1 for now. 2 wrong. 3 wrong. 3 wrong out of 10. We have a 70 out of 100 for now, and see you in the next one.